Welcome, everybody. Thank you so much for taking the time to be here this evening for our Innovations in Gastrointestinal Oncology, or GI webinar. I'm Dr. Jenny Permuth, Moffitt's first Vice Chair of Research in the Department of GI Oncology. And in this leadership role and in my role as a patient advocate, I'm committed to accelerating research efforts for individuals with or at risk for GI malignancies. March is Colorectal Cancer Awareness Month, and as we know, colorectal cancer is now the third most common cancer in both men and women, with an estimated 150,000 new cases expected this year, 12,000 of which will occur in our state of Florida. As such, today's webinar content will focus on colorectal cancer and a common site of metastasis, the peritoneum, or the inner lining of the abdomen. In a few moments, I'll be introducing you to my colleagues, and I'm confident you'll find value in the information we will share with you tonight. But before we begin, please be advised that the content is not intended to be medical advice, and viewers should consult their physician should they have any questions. Viewers should not rely on information contained in this presentation or webinar for immediate or urgent medical needs. Additionally, if you think you may have a medical emergency, call your physician, go to the nearest emergency department, or call 911 immediately. Never disregard professional medical advice or delay seeking care because of information contained in this presentation. Again, we're so pleased to have you with us tonight. And I want to remind you that after we hear from all of our speakers, you'll have an opportunity to have your questions answered by these experts. We invite you to type your questions into the question and answer box located at the bottom of your screen. And now I'm pleased to introduce Dr. Felder. Dr. Seth Felder is a surgical oncologist in our department who will be speaking for about 8 to 10 minutes to provide an overview on colorectal cancer. Dr. Felder, feel free to take it away.
Thank you so much, Dr. Permuth. I'm excited to be here today. I'm happy you've all been able to join this evening, and I'm happy to be part of this this webinar with my colleagues as well. So my portion of this discussion is really going to focus on a high-level view introduction to colorectal cancer. I'm a colorectal surgeon, and we'll touch on some of those parts. Dr. Iman Imanirad will then clarify some additional treatment options for patients with more advanced disease, and Dr. Dineen will then discuss more about patterns of how this disease can progress in the body. So as you can see here, colorectal cancer is a common cancer, unfortunately. It's the fourth most common in the US among women and men, the second leading cause of cancer death in the United States. But what's critically important is that it can be prevented with appropriate screening. And when it is identified at an early stage, it is very treatable and often curable. In fact, for the earliest stage of colorectal cancer, we expect at least a 90% survival rate. There's about 150,000 people estimated to be diagnosed in the United States in the coming year, and about 50,000 patients will pass with colorectal cancer. There's about a 1 in 5 or 4% or so risk for developing colorectal cancer over the course of a lifetime, and we're going to go through some of those risk factors, patients that may be at a lower or higher risk, with the average age in the mid-60s. We'll talk a little bit more about that and how that has implications for screening and the relevance of that, where we hear about early onset colorectal cancers in the media, and we're seeing that more commonly in the clinic. So if we can move on to our next slide. So here we see young onset, which is typically defined as those that are younger than age 50. Typically, cancer in general is a disease of aging, but more and more we're seeing younger patients. Now, this is increasing in incidence, and it's not a reflection of increased screening with earlier detection of these lesions at earlier stages. In fact, many of these are being found at later stages because it's really not in our minds that someone so young may develop a cancer. And so symptoms may go on for many months before the diagnosis is established. And so you can see here about 10% of colorectal cancers appear in patients that are younger than age 50, and most of these are between the ages of 40 and 50, though we see sometimes patients in their 20s or 30s. It's estimated by 2030, about 10 to 11% of colon cancers and about 23% of rectal cancers, which is the last part of the colon, will occur at an early age, so less than the age of 50. This is increasing dramatically as opposed to what we would consider average onset, which is decreasing and attributable mostly to screening. These tumors in younger patients are typically in the rectum or the last part of the colon. It's unclear why. There's a lot of research in this field, but the causes and the risk factors, these are all still being heavily researched and really not well understood at this point. So more recently, in the last few years, we've seen some guidelines change to recommend screening colonoscopy at age 45 for patients that otherwise would be considered average risk. So the age of screening has now moved from 50 to 45. Next slide. So what are some risk factors that are established or possible? Well, again, cancer is often a disease of older individuals. Again, we're seeing younger patients, but the majority are older individuals. Now, we think of risk factors, what is modifiable versus not modifiable, and what will impact or influence screening recommendations. And you can see here there's a lot of factors at play, and a lot of these are still unclear. You know, alcohol consumption, smoking, we know these are not necessarily good for us in excess or at any use of it for smoking. But its direct causal relationship to causing a cancer is not really well established. Specifically, when I say that, particularly in the young onset, you know, we see patients that are overweight, underweight, smokers, non-smokers. So there's a lot of research, and a lot of that is learning about what you can see here. There's something called the microbiome, and that's sort of the body's interaction between the bacteria that is normally within us and its relationship to the immune system, and how that interacts may in fact have significant influence on individuals' risk for developing cancers. Next. How do I know my specific level of risk? So, you know, oftentimes when I see patients in the clinic, there really is no identifiable risk factor. I often say it's poor luck. You know, at this point, it's not something that we can put our finger on and say, this is, you know, what is causative of that tumor. Most patients are what we would classify as a sporadic risk, meaning nobody in the family has a cancer. You don't have any indication that you've inherited something genetically from family to increase your risk. And this is where we see the lifetime risk of developing a colorectal cancer being around 4%. This accounts for the majority of colorectal cancers, greater than 70% probably. The remainder is made up of familial risk, so a first-degree relative, say a parent or brother or sister that has a colorectal cancer. That increases, especially if they're younger, that increases your risk maybe 2 times over a lifetime. And the more family members, that can increase your risk even more. And the last component is what we call hereditary risk. And these are genetically identified mutations that are related to syndromes that make individuals more likely to develop a cancer. This is the minority of patients. There are some syndromes that carry almost 100% risk of developing a colorectal cancer. But the most common, called Lynch syndrome, which is probably around 3 to 5% of patients, carry about a 30 to 60% risk of developing a colorectal cancer, as well as other cancers that are related to those syndromes. Next. So when do you suspect these? Well, younger age, multiple generations of cancers, multiple individuals with a same type of cancer, rare types, individuals with multiple cancer diagnoses, so a colorectal cancer and say a stomach cancer, high-risk racial or ethnic groups. So we know that some Black patients can be at higher risk as well. At this point, though, there's really no difference as far as screening recommendations, but these should clue us into suspecting a potential hereditary component or a higher risk to potentially reflexively get someone evaluated earlier or sooner, or have a genetic counselor even weigh in. Next. So symptoms, these could be non-specific, but bleeding, change in bowel habits, these can often be attributed to things like hemorrhoids or irritable bowel syndrome and discounted. I would encourage, if these symptoms are persistent and not improving, they need to be assessed. We can't just chalk it up to that's hemorrhoids, although that's a common entity and the most common. That sometimes turns out that there's a delay in diagnosis because an exam was not done. Next. What about staging? So colorectal is staged based on what we call the AJCC staging system. And so we have stage 0 to 4. 0 is basically a lesion that has no capacity to go anywhere in your body. It's a precursor lesion or precancerous. Stage 1 through 3, we typically treat as curative intent treatments, and often with surgical intervention, and sometimes with additional treatments, including chemotherapies or radiation treatments. Stage 4 is when the tumor has been able to escape the localized area and go to a secondary organ or part of the body, which Dr. Dineen will talk in great detail about as well. So if we can go to the next slide. The stage is something we use as part of the workup when the diagnosis is obtained to understand what the best treatment is for the individual patient. Like I said, if it's a localized tumor, often surgery is part of the treatment plan, or could be the treatment plan. So you can see here, this is illustrations of the colon with representations of a tumor in different segments. And we base our extent of resection on where it is, the drainage of the lymph nodes, which are carried along the blood vessels. And I explain it as like a pipe that we cut two ends with the drainage of the lymph nodes, deliver that to the pathologist, and then we have to reconnect the two ends back together. We use different techniques, and one of them you can see here. This is the platform that uses the robotic instruments. And essentially, it's a surgeon-controlled device, but allows us to have a lot of precision and good visualization in the abdomen when we're doing that surgery, and hopefully improve recovery time as well. Next. So to wrap things up, I just wanted to bring attention to some of the things we're doing here with colorectal cancer. So this is an example of a rectal tumor that typically, after being worked up, is treated with different forms of therapy, including chemotherapies and radiation. And you can see how the tumor shrunk down, and on the right, there appears to be just a scar left with these little fine capillaries. Generally speaking, most are recommended to undergo a rectal resection, which is outlined on the right side, which is oftentimes a significant operation and certainly can affect patients' quality of life. But what we've learned is some people may be cured by those preoperative treatments alone and may be able to defer or avoid surgery. Next. And so you can see here, this lists trials over the last decades where patients have been given those treatments, chemotherapies, radiations preoperatively. They've undergone surgery, and they found that almost a third of them in these trials have had no residual cancer left. And so what we've been trying to research here is, are we able to apply specific techniques where in this context we used tumor-informed signatures to inform our radiation doses to potentially increase that number so that we can hopefully get more patients cured with these diseases, also preserving their quality of life.
Thank you for that excellent presentation, Dr. Felder. We already have some great questions coming in to ask you about later. And thanks especially for commenting on the climbing rates of early onset disease that we're seeing in the population. And I know our panel here wanted to share with this audience that we see this group, and we know that there are unique physical and emotional and spiritual needs that need to be met for these individuals and their families, and we are working together with some community partners to support those needs with a new clinic we hope to roll out later this year. So more to come on that. Next, I'm excited to introduce to you Dr. Iman Imanirad. He is a medical oncologist here at Moffitt Cancer Center, and will be talking to you about therapeutic strategies for colorectal cancer. Dr. Imanirad.
Thank you very much, Dr. Permuth, and thank you, Foundation, for having me tonight. I'm excited for the rest of this presentation. Dr. Felder did already a great job of going through some of the basic. I'll take it over from here with some aspect of chemotherapy and systemic therapy. So hopefully the audience who actually made the effort to join us tonight is going to find some helpful hints as to what, as medical oncologists, we do at the medical oncology clinic. So as a medical oncologist, what we do is in the clinic is, for the most part, systemic therapy. And oftentimes, this is equated with chemotherapy. For the most part, that's true. You know, we do a lot of chemotherapy, and that's almost equal to chemotherapy. But we do a little bit beyond. And for drugs that have been developed over time, there has been targets, and that targets kind of like falls in the span of proteins on the cell surface all the way to the cells, effector cells of immune system. And therefore, we kind of like put them in different categories of targeted therapies, immunotherapies, and also some cell-based therapies. It is also important to note that when we talk to our patients in the clinic, the philosophy, the overarching philosophy of treatment typically falls under two different categories. Either we are talking about curative approach or we're talking about palliative approach. And within the curative approach, if you're doing chemotherapy, oftentimes either before or after surgery, it is called neoadjuvant or adjuvant treatment, and that's geared towards improving the survival, towards the cure rate. You know, some people regard this as an insurance chemotherapy or mop-up chemotherapy. Essentially, the surgery takes care of the disease, and chemotherapy is adding to the likelihood of cure. There are certain cancers like lymphomas, for example, where chemotherapy is the main treatment. No surgery is typically considered, and chemotherapy becomes the main treatment or definitive treatment. Under palliative treatment, which is typically done with later stage cancer centers, like stage 4, for instance. The goal of treatment is to extend longevity and to improve quality of life. And there are different strategies we use, including using high-dose chemotherapy at the beginning, then de-escalating and reducing the intensity to maintenance, or using strategies, for instance, such as stop and go, doing chemotherapy for some time, taking some breaks, and etc. Mind you, going through the details is not going to be the purpose of this talk. We're going to touch on the surface of different drugs and kind of like different modalities that we use in the GI medical clinic. So this slide, I made it myself, and as I was making them, I reflected upon kind of like the history of different medications that have been approved over the past several decades for colorectal cancers, and the long way that we've so far come. All the way from 65 years ago, when 5-FU was pretty much our main treatment. And for about 3-4 decades, we didn't have any other real effective agent until the early 90s, when we started having more novel chemotherapeutic agents, which are irinotecan and oxaliplatin. And since then, essentially, it has been a number of different agents, which are either, for the most part, targeted therapy or immunotherapy, as early as actually as latest as November of 2023, when the last agent was approved. Next slide, please. For chemotherapy, you may have heard certain regimens, including FOLFOX and FOLFIRI. These are the terminologies that we use to define a regimen, which is a combination of different drugs. 5-FU, as I already mentioned, has been one of the main treatments for several decades. And once we combine it with oxaliplatin, we call the regimen FOLFOX. Folinic acid is not a chemotherapeutic agent, it's rather a kind of like vitamin similar to folic acid, which augments the effect of chemotherapy. And those two regimens are kind of like the most commonly used regimens in people who are maybe younger and better organ status and more active. We combine all drugs together, and it's a regimen called FOLFOXIRI. The reason that I'm even bringing that up as an example is to again highlight that these regimens are kind of like the backbone of regimens, and oftentimes, not necessarily always, the targeted therapies that we talk about often in the clinic kind of like stand on the shoulder of this backbone chemotherapy, something that I sometimes in the clinic refer them to as icing on a cake. There are examples like FOLFOX and bevacizumab, the old name for it, Avastin, or FOLFIRI and cetuximab, which I'm going to discuss a little bit in the next few slides. Next slide, please. But before I get to those targeted therapies, let's very briefly touch base on earlier stage colon cancer. As Dr. Felder mentioned, typically for stage 1 colon cancer, which is a superficial malignancy within the lumen of colon, surgery would suffice. You know, the survival rate of somewhere upward of 90% is expected, and it's unlikely that additional chemotherapy is going to improve upon that. For stage 3 cancers, these are the ones that we have nodal involvement, when the lymph nodes are involved within the surgical specimen that has resected. We typically offer chemotherapy. And again, within the spectrum of stage 3 colon cancer, you know, there are cases that we call low risk, which we treat with 3 months of chemotherapy, and there are cases that we define as high risk. These are the ones that have more positive nodes and maybe more extensive tumor in the actual colon specimen itself. And for those ones, we typically offer 6 months of chemotherapy. For stage 2 colon cancer, jury's out. You know, it can go either way sometimes. There are certain clinical features. If, for example, a patient presents with perforations or obstructions, or there are certain adverse features under the microscope, then we may consider chemotherapy under those circumstances. And depending on the high risk or low risk, again, it could be 6 months of oral or IV chemotherapy with 5-FU or capecitabine, or 3 months of oxaliplatin-based chemotherapy. Next slide, please. But really, what we've been trying to actually make more progress is the stage 4 colorectal cancer. And there has been, over the recent years, a recognition of targets, something that what we call actionable mutations or actionable genomic alterations, which have allowed us to develop certain drugs to fight colorectal cancer. As you can see in the central picture, there are mutations such as KRAS and NRAS, where the absence of which actually provide us targets. There is another mutation called BRAF, which comprises approximately 8 to 15% of colorectal cancers, and that has some agents that has been approved. There are HER2 amplifications as well as MSI high, for which we are using drugs, which I'm going to talk about in a bit, for including immunotherapy and other targeted therapies. It is also noteworthy to mention that the sidedness of colorectal cancer, or colon cancer, I should say, does matter in the type of treatment that we choose. As you can see on the bottom left, there are certain mutations that tend to distribute more on the right side of the colon, and certain mutations that tend to distribute more on the left side of the colon. And they would often call for different therapeutic approach and a treatment that would be more personalized to that particular case or patient. Next slide, please. So with that in mind, I'm going to go ahead and briefly talk about some of the common targeted therapies that we use in combination with chemotherapy. We have one agent called bevacizumab, which is an antivascular endothelial growth factor, or VEGF. There are other agents within this category, and all they do is inhibit a factor in the blood circulation called VEGF, as you would do, or the receptor that this factor attaches on to the cancer cells, which ultimately allows cell motility, vascular permeability, and the ability for the cancer cells to go from one spot to another, or metastasize, in other words. These drugs have shown in several clinical trials to improve outcomes, to improve disease control, and to improve survival, extend survival, I should say. And but then that doesn't come without any side effects. The typical side effect associated with this class of drugs is as you would expect from their impact or influence on the blood vessels. That includes increase in blood pressure. That includes healing problems if there was any wounds or surgery, for instance. That includes spillage of protein in the urine because of their impact on the tiny capillaries that are within the renal system. Also, blood clots were in the venous system or arterial system, heart attack, stroke, and bowel perforation. Although in very low incident, but there are possibilities with this class of medications. Next slide, please. The other drugs are two drugs, cetuximab and panitumumab, which are epidermal growth factor receptor blockers. As I pointed out earlier, these are typically effective if the KRAS, NRAS, and BRAF, which belong to kind of like a cascade of pathways within the cell, are wild type. Wild type means that there's no mutation involved. And the two drugs, one of them, as I mentioned, cetuximab, is a chimeric drug, which is kind of like a large protein, which is partly mouse origin and partly human, and panitumumab, which is fully humanized. There are side effects associated with these drugs, but the most notable one is a side effect called acneiform rash, which tends to happen for the most part in the facial area, upper chest, and upper back area. Sometimes it can cause inflammation around the nail beds called paronychias. Several things interesting about the rash is that there are studies to suggest that the worse the rash, the better the outcomes. So as you can see on the right, the blue line is more severe rash, and that has actually pulled the survival curves to the better side. The second thing is that even though, yes, the rash is maybe associated with better survival, but it's very unpleasant. Actually, about 70 to 80% of the people do experiencing, and a lot of people actually discontinue these drugs because of the rash and because of the symptoms that it does cause. So it's important to manage the rash effectively. And we have a clinical trial here at Moffitt that we've been running in the past year and a half, using a topical cream to ensure that patients actually get treated for the rash and they can continue on their treatments. The other target is a BRAF target, which, as I mentioned on the previous one, the cetuximab blocks the EGFR, but also if this is mutation, it's kind of like works as a switch on that we require to actually block the pathway into different points. And this regimen has been also shown to be extremely effective. Unfortunately, patients with BRAF V600E have a less favorable prognosis, but this has been shown to improve survival. Next slide, please. Same thing with HER2 amplification. This is something that we see more common with breast cancer, but also about 40% response rate with people who have been heavily treated with different regimens with colorectal cancer, respond very nicely to a combination of tucatinib with trastuzumab. Next slide, please. There has been a number of other targets, including KRAS G12C and other KRAS mutation for which there are clinical trials ongoing. And we also have clinical trials that we accrued several patients within the past year for different targeted agents. Next slide, please. Immunotherapy has gained a lot of interest over the recent years. This is people with immunotherapy have a condition called MMR deficient or deficiency that's within the tumor, but that could be within the context of, as Dr. Felder mentioned, hereditary syndromes. These cases respond very nicely to immunotherapy. On the bottom, you can see a picture of a patient with peritoneal disease on the PET scan who responded very nicely to immunotherapy and went into complete remission. Next slide, please. And as you can see, pembrolizumab or Keytruda has been approved for several years now for a number of cases, including MMR deficient colorectal cancers with significant improvement in oncologic outcomes. Next slide, please. Lastly, for the next minute, I'll kind of review the role of ctDNA. You probably come across different kind of like assays in the social media or in the news. One of them is Signatera, which is tumor-informed, and the other one is Guardant Reveal, which only requires blood. These are being found to be useful in several clinical utilities, including minimal residual disease, including providing prognostic information for chemotherapy, and also monitoring for response. There's also some new technologies coming for screening purposes, which might be beyond the scope of this talk. We do have, next slide, please. We do have a clinical trial for stage 2 and 3 patients. We do adjuvant chemotherapy to a lot of patients, and they may not need it. So we are trying to make it more personalized and designing chemotherapy based on ctDNA after the surgery. And if it's positive, patients may get more chemotherapy for FOLFIRINOX or for FOXIRI, as I said at the beginning. And if it's negative, we are seeing if we can potentially spare the patients of side effects of chemotherapy and put them on observation and watch them closely. And this is yet another clinical that we have at Moffitt called Circulate US. We are one of the sites in the United States, and we are glad to be part of it. With that, I will end my part here and pass on the baton to Dr. Dineen.
Thank you so much for that informative presentation, Dr. Imanirad. I really appreciated how you pointed out clinical trial opportunities for our patients, and it's an honor to watch you all behind the scenes working hard to design them and open them. Dr. Dineen is a surgical oncologist who is going to be talking to us today about peritoneal disease. Take it away, Dr. Dineen.
Thank you, Dr. Permuth. Appreciate all the insight from my colleagues. It's such a wonderful opportunity to work here and to be able to take care of patients with members of the team like Dr. Felder and Dr. Imanirad. I do have a couple of disclosures. I have taken some consulting fees from a company called OncoInvent, which is interested in the treatment of peritoneal disease, but I won't specifically discuss them tonight. Intraperitoneal chemotherapy is considered off-label use by the FDA. And so any discussion about HIPEC is considered off-label use. And then just lastly, before I get started, 2 things. I'd like to apologize for my voice. I think I've been a victim of the pollen in the air, so hopefully I'll make it through. And then I'd like to thank all the patients for the opportunity to, again, be a part of this team. And it's a real privilege to be able to take care of everybody. And I see a lot of familiar names on the chat. So I'm going to talk about peritoneal disease tonight. And so that begs the first question of what is peritoneal disease? And the peritoneum is a lining of the abdominal cavity. And what's shown here on the top right of the screen is the development of the peritoneum from an embryological standpoint. And that's a relatively complicated process. But the point here is that it's a roughly cylindrical shape that surrounds both the lining of the abdominal cavity, and then in the middle there you can see that there's a thin lining that ultimately envelops the intestine as well. Next slide. I think this is my only real surgical picture, which they had to make smaller. So, it's the part of the picture there on the right is what a peritoneal implant looks like. And really all of the white there is cancer. And this is an image of the diaphragm. And in the center there is the thickest part of the tumor. But even so, and it maybe doesn't project great, but it's not a very thick tumor. And it sometimes can be, it's not real discrete. It's more like a sheet. And so the picture on the left, the cheese, and I understand that only surgeons put food and surgical pictures next to each other, but the cheese slice that we're all familiar with has this, cellophane wrapper. And what we try to do, and I'll talk more about the surgery, but when we do surgery, we try to basically peel off that cellophane wrapper where the tumor is stuck, leaving behind the tissue underneath, which in this example is the cheese. So we can go to the next slide. So for some background in terms of kind of the incidence of peritoneal disease, about 7 to 30% of patients with colorectal cancer will develop peritoneal metastases. And of those, about half will be isolated to the peritoneum, meaning the only site of metastatic disease is the peritoneum. And so if we take the numbers that have been discussed before, where colorectal cancer is a very common cancer, this is a small subset of those patients, but it's still a fairly sizable number. So this still represents an important group to study. We also know risk factors for peritoneal metastases. Those are listed on the slide, but basically the T4 tumor is a tumor that has basically grown through the outermost lining of the colon. And Dr. Felder had a good slide showing that. And that's a risk factor for development of what we call seeding, or cancer cells that have kind of broken off from the tumor itself and have implanted within the peritoneum somewhere. The outcomes, sorry, if you'll just go back, the outcomes for peritoneal disease are worse than for patients that have cancer that has spread to other sites. And I don't have a lot of time to go through all that detail today, but basically for patients that have had cancer, a colon cancer that spread to the liver or to the lung, they tend to respond slightly better to systemic chemotherapy than do patients that have had cancer spread to the peritoneum. Now we can go next slide. So when we think about surgical treatment for patients that have colorectal cancer with peritoneal disease, and this is applied to some other cancers as well, what we're typically talking about is cytoreductive surgery and HIPEC. HIPEC stands for hyperthermic intraperitoneal chemotherapy. So we'll talk about CRS HIPEC. So this is a surgical treatment that can be applied in select instances of peritoneal dissemination of disease. And so the first, the first part of the decision-making process for whether this is an appropriate surgical treatment starts with the cancer type itself. So for the purposes of today's talk, we're focused on colorectal cancer, but the indications are slightly different for appendix cancer. They're quite different for gastric cancer and for peritoneal mesothelioma. So we'll talk about what the indications are tonight for patients that have colorectal cancer. I'll skip to the last bullet point there. The operative phases here are typically an exploratory phase where we start out with an incision that's usually the whole length of the abdomen. We try to make an assessment to ensure that the tumor is suitable for resection. Once we do that, we perform the cytoreduction. That's the surgical removal of the tumor. And there's another slide to outline that. The perfusion part is the HIPEC. That's when we introduce a chemotherapy bath or a chemotherapy solution that washes over all of the peritoneal surfaces. And that's what's depicted in that figure there on the right. And then after the HIPEC is done, which is typically 90 minutes, we'll do the reconstruction. Usually the HIPEC is done with either mitomycin C, or in the past, it had been done with oxaliplatin. We've moved away from oxaliplatin in colon cancer for the most part, based on some data that came out a few years ago. Next slide. So this outlines those phases that I just mentioned. So if we look at the cytoreductive phase, which is the second box there, this kind of outlines a lot of the potential parts of the operation that we might do. And technically, this is actually a edited figure. There's another 2 or 3 sections that continue off to the right. But basically, the point of this isn't to indicate all, to go through each one of these individually, but just to indicate that this can be a very extensive operation that can involve a lot of different parts of surgery. So visceral resections involve resection of a portion of the bowel typically. So that can happen in a lot of different areas. The peritoneal resections can happen all over the abdominal and pelvic cavity. The abdominal wall can be involved. So this is how the operation can become quite long. The average is somewhere around a 10-hour operation. And you can see that the different areas that we need to work on are partly why. The HIPEC phase, as I mentioned, that's the chemoperfusion, and then the reconstruction is where we kind of put everything back together. So next slide. So you can imagine when we're doing all that, this can sometimes feel like a marathon certainly for the patients that have gone through this, and again, there's some on the line, this is a long process, and the surgery is really just the first part of it. So next slide. So who should undergo CRS-HIPEC for colon cancer? The figure there on the left is data from a multi-institutional collaborative group that we were a part of. And this represents about 400 patients with colon cancer who underwent what we would consider an appropriate surgery. So we were able to remove all or nearly all of the visible disease. And the important point to focus on here is the blue line at the top and the red line at the bottom there. And basically what that is that's the extremes in terms of how much tumor was identified at the time of surgery. We grade that using a PCI score, or a peritoneal carcinomatosis index score. And so those are the groups there listed at the bottom, PCI 0 to 4, all the way to PCI greater than 20. And as you can see, the PCI 0 to 4, which is the lowest volume group, they do the best. So that top line there represents the group that has the longest survival. The red line is the group that has a PCI of 20 or greater. That would represent fairly advanced disease. And you can see that that group, based on the curve, has the lowest survival. The other groups basically correlate to the sort of increasing extent of disease with decreasing survival. So one of the things that we look at is the extent of disease. And the lower the volume of disease, the better. The other thing that we look at is, are we able to get this all out? And there's a lot of different studies that have shown this in different ways, but the study on the right there is from a paper that came out in 2003, so over 20 years ago. And this was one of the original papers that looked at the effectiveness of cytoreductive surgery in HIPEC for this disease. And the top line there is the group that had the best surgery with respect to clearing all of the disease. So the group with the best survival there is the group where all of the visible disease was removed. Next slide, please. So now it comes to the time of, determining if we think that the patient has small to moderate volume disease, we think that we're likely to be able to clear all of the disease from a surgical standpoint, we have to balance the benefits and risks of the operation itself. And I've just put two studies up that kind of help inform this decision a little bit. So on the left is what we call the PRODIGE 7 study. And this is one of the better studies that looks at the potential benefits of cytoreductive surgery in HIPEC. And then on the right is a study that we were a part of from that same multi-institutional collaborative that looked at some of the complication risks associated with undergoing CRS-HIPEC. So the study on the left there, sorry if we go back, the study on the left there is sometimes thought of as a negative trial, and that's just because this is one of the studies that showed oxaliplatin doesn't work very well. But what it established is that the survival after surgery for CRS-HIPEC is about 3.5 years, 3.5 to 4 years. So that's a pretty good number that we can use in a select group of patients here. But on the right, we know that the complication risk is pretty high. So while mortality or death related to surgery is fairly low, only about 3 to 4% in the surgical window, the risk of a complication is fairly high. So that's about 50% of patients will experience some complication. And we know that quality of life after this operation drops a little bit. So we're able to, balance these things, the survival of the surgery with the potential impact on the quality of life. So next slide, please. So the algorithm that we use here at Moffitt is indicated here. So patients with colorectal cancer and peritoneal disease will typically undergo systemic chemotherapy, like what Dr. Imanirad mentioned, for about 6 months. We will then, most of the time, do what we call a diagnostic laparoscopy, which is usually an outpatient procedure where we go in through small incisions with a camera and look inside to try to determine the full extent of the tumor. This gives us an estimate of the PCI score that I mentioned earlier and helps us to categorize patients into either high PCI or low PCI. And that gets back to that burden of disease. Patients that have a high burden of disease have a very high recurrence risk. And so in that balancing figure that we were thinking about, the surgery tends not to be that beneficial in this cohort of patients. So we'll usually recommend continued systemic chemotherapy in that group of patients. For patients that have a low PCI score, we'll typically recommend cytoreductive surgery and HIPEC in that cohort because we think that they fulfill those sort of two criteria that we talked about at the beginning, low PCI, and we're able to clear the entirety of the tumor. Next slide. Next couple slides are just going to highlight a few of the ongoing studies that we have here. So this one highlights a study that we're doing in combination with Kia Turner from the Moffitt Research Institute. And what we're really looking at here is is there a way to talk about this? Because as you can tell, this is a difficult topic to understand all the nuances of. But is there a way that we can use a decision aid or computer-based software to help patients understand the potential risks and benefits of this operation a little better? And that's in collaboration with the group that's developed the software here. Next slide. This is a interesting study that has just recently come out. And I'll just briefly say that if we think that low volume disease is really the sweet spot in terms of when to offer the surgery, this study looks at basically just patients with high risk tumors. So if we just look at those T4 tumors that I mentioned at the beginning that we know have a high risk of peritoneal disease, but patients don't have it yet, is there a benefit to doing a prophylactic HIPEC, to just go in and do the HIPEC after the surgery? Those two lines there indicate that there is some benefit to HIPEC compared to surgery alone. So this is an area that this is pretty new and slightly controversial at this point, but I think this is an area where we can start to try to investigate this early intervention, even perhaps before the development of peritoneal disease health. Next slide. And then finally, we've been talking a lot about CRS HIPEC, and that's again for patients in whom we think we can clear out all of this tumor. But that's only it's actually less than 50% of the patients that I see are candidates for CRS HIPEC. So what options do we have for the patients that are not candidates for that? And one that has become fairly popular in Europe, not quite so much here in the US, is what we call PIPEC, or pressurized intraperitoneal aerosolized chemotherapy. And these are technically surgical pictures, but they don't show too much other than this is a minimally invasive procedure done through laparoscopy where we put in an aerosolizer. That's the tubing in the center there. And the chemotherapy, rather than being delivered in solution, is delivered in an aerosolized fashion, kind of like a nebulizer for asthma. That sort of sits in the abdominal cavity for about 30 minutes and then is evacuated. And this has some promise in the fact that it's minimally invasive, can be repeated multiple times, and seems to give at least equivalent results to systemic treatment. Next slide. And then finally, we are looking at some of the effects of targeting alpha particles into the peritoneum. So this relates a little bit to these radiopharmaceuticals where we can use a marker that's expressed on the surface of the cancer cell. In this figure, it's this MUC16 protein. And then we can link that to a radionucleotide, so basically radiation. And then we can use that target to try to attach the radiation directly to the cancer cell. And so in this way, we can hopefully make this a more targeted radiation, so we don't have to radiate the entire abdomen. And there is also potential that something like this could be delivered in a minimally invasive fashion as well. Next slide. Okay, the last one here, I think, is another project that we're working on where we're really trying to take mucin. So a lot of these tumors that I've described are mucinous. meaning if you take a tumor that's maybe the size of a golf ball, most of that will just be mucus rather than cancer cells. And is there a way to try to really break up that mucus for different things, to get chemotherapy to it better, to make it drain easier? And we're working with the bioengineering group here. We actually have an expert on mucus and Dr. Greg Sawyer, and we're really trying to focus on ways to break up that mucus and then allow for the treatment to be targeted to the cancer cells better. And I think next slide, this is, I hope, my last slide. So cytoreductive surgery in HIPEC is a surgical procedure that should be considered for select patients with colorectal cancer and peritoneal disease. We've talked about the criteria, so low volume disease, ability to achieve a complete cytoreduction, should be done in an experienced center like ours here. Novel approaches such as PIPEC for unresectable disease are emerging, and then we need to continue to pursue new ways, new research avenues to better understand how we can treat this. And with that, I'll take the next slide, which I think is the end. So sorry I went a little bit over there. Thank you.
No, thank you so much, Dr. Dineen. It was really exciting to hear about those new innovative lines of research that the team is pursuing, thanks to philanthropic dollars. And that's a great segue to introduce David Curry from the Moffitt Foundation, who's going to say a few words.
Thank you, Dr. Permuth, and thank you, Dr. Dineen, Dr. Felder, Dr. Imanirad. Your presentations were insightful, and I think for myself, they inspired hope. So really appreciate you doing that. Also, I want to say a special thanks to my foundation colleagues, Stacy Price and Brielle Humphreys. They've been working behind the scenes tonight to make sure that producing this webinar and providing you something special. But more importantly, I want to thank all of our participants tonight. You've given up your valuable time to join in and to learn from some of the world's very best. So I hope you've enjoyed everything so far. I would say, too, that you make sure you put your questions out still. If they don't get answered tonight, we will follow up with the doctors and make sure that you get the answer that you're looking for. And I would like to say, finally, if you've been inspired by what you've heard tonight, and you'd like to learn how you might be able to help to advance this important work, please contact me at your convenience, and I will look forward to speaking with you soon. And so with that, Dr. Permuth, we're ready to move into the Q&A.
Thank you so much, David, and for all you do with us in collaboration with all the patients that we serve. So now is the exciting time where we invite you to ask questions, put them in the Q&A box. We'll try to answer as many as we can, and I will be announcing the last question when we get to that point. But I've got a couple specific questions for some of our faculty members, and then a more broad question. But Dr. Imanirad, this first one's for you. For patients with stage 4 disease who get their mutations tested through Foundation DX or other panels, is there a need to get this testing redone at another time? Can one's tumor mutation burden change? Could you comment on that?
Yeah, thank you for the question. And the short answer is yes. There's also a long answer, however, because there are certain mutations that are rather very, very, I would say, ancestral. They actually form not only just at the cancer, but from the polyp that the cancer had come from, like KRAS mutations or APC mutations. These are mutations that are early on and unlikely to change that throughout the course of treatments. However, we do have, like, let's say, treatments with anti-EGFR therapies that I just mentioned that can breed resistance into the cancer, and redoing liquid biopsies or even biopsies of the sites where cancer is progressing does, in my opinion, have a definite role. Whether TMB high or low and whether changing the TMB, I believe the jury is a little still out on that, because that ties into the question of immunotherapy. And immunotherapy for TMB high colorectal cancer. There are some data from, for example, TAPOR trial, which is from ASCO, suggesting good disease control, but there are also some data to suggest that TMB high for colorectal cancer might not be just as good of a predictor as, for example, it is for lung cancer or other malignancies. But then again, I went back kind of like a circle to come back and say, yes, I definitely think that there's a role to retest based on the proper clinical setting.
Great. Thank you so much,
Yeah.
Dr. Imanirad. The next few questions are related, and they're going to go to Dr. Dineen, and they relate to the pipette procedure. Can you tell us about when we might expect to see this in the future at Moffitt?
Yeah, so we have a trial here at Moffitt that we've written, and it's a phase 1 study to look at using mitomycin C as the chemotherapy agent in pipette. We have I guess some kind of logistic hurdles that we're trying to work through. Once hopefully we can start to work through those. And if so, I think that we could get the trial open ideally this year. Because I think the pieces are in place here to be able to do that. And so that would be our goal.
Great. And some audience members have heard about a new method of treatment called electrostatic pipette.
Yeah.
Can you just comment on that?
Yeah. So that is sort of combines the pipette, which is the aerosolized chemotherapy, with basically magnets to try and direct the aerosolized particles into the tissue. It's a pretty interesting process when you see it, because you'll see this aerosolized kind of spray, and then the magnet goes on and it all flips over to the side. That's kind of a next level of pipette in terms of really trying to see if that actually adds anything. It works in the sense that the chemotherapy is delivered into the tissue a little bit better, but it's almost it may be that it works too well, and that the chemotherapy goes into the tissue and then directly into the circulation, because the circulating levels of the chemotherapy have been found to be pretty high after the e-pipette. And really what you want is that contact of the chemotherapy onto the tissue itself.
Great. Thank you, Dr. Dineen. I know a lot more questions related to HIPEC are coming in, and we'll have to answer those offline. Just wanted to ask Dr. Felder something, because we haven't gotten to him yet. Last week there was a study published in the New England Journal of Medicine about a cell-free DNA blood test for colorectal cancer screening. Can you comment briefly on the study and whether you think this new test could help bridge the gap of accessibility and get more adults screened regularly?
Yeah, absolutely. Thanks for that question. So yeah, this is clearly a important topic. As I mentioned earlier, if we knew and could screen patients and identify these at an early stage, we would have less of this more advanced disease, less peritoneal disease. Obviously, some of these cancers, despite screening, do appear. So the message is, if you qualify or you're considering screening, the best test is the test that gets done. There was a national effort to get colonoscopy rate for those that are indicated for a screening colonoscopy to around 80%. And I think that target was somewhere around 2017, and it didn't meet that goal, and it still has not. So many people that should be screened are not, and there are different mechanisms for screening. We usually compare it to the gold standard colonoscopy, because that has the potential to not only diagnose, but also potentially remove precursor lesions like polyps that can intercept that progression to a future cancer. Now, these other tests, there's other stool-based tests like the Cologuard test that you may have heard of. This is a blood-based test, which may be much more accessible, are certainly options. This is yet to be, I think, the blood test into the screening armamentarium at this point, but I think it soon will be an option. The caveats with these other tests, with the gold standard of a colonoscopy, is that they have limited sensitivity or ability to detect polyps. Excuse me. So advanced polyps, which are at-risk polyps for a higher likelihood of developing into a colon or rectal cancer, the sensitivity is a bit low. And so you're not really detecting all those. And so, a colonoscopy would likely detect those. And so I think as these tests improve, it will become increasingly used. And there certainly is a huge role for these types of tests in the future.
Great, thank you. And then the last question for the night, big picture, what are you most excited about in terms of research breakthroughs in this field for any of the panelists? Let's end on a sentiment of hope here.
I'll go first, or I'll take that one. I mean, I think I'll say a two-part answer. I think that I'm excited, and this will go back to what I said before. I think a group like what we've assembled here is really exciting in terms of the collaborations that we have between, you know, surgeons like Dr. Felder, chemotherapy doctors like Dr. Imanirad, who know that in and out, researchers like yourself, Dr. Permuth. We have a team here that I think is incredibly well positioned to start to answer some of these really tough questions. And I think, you know, one thing that has kind of combined or hit on all of these topics that you've heard tonight is the environment in which the cancer grows. And I think we're starting to really try to look at what are the specifics of the microenvironment where a colon cancer grows. How do we get chemotherapy into the cancer itself? Is the peritoneum a different microenvironment? And I think that's an area that sort of overlaps with the immune system. So what are the immune cells in that microenvironment? That kind of ties all of these different aspects of the progression of colon cancer.
Thank you so much, Dr. Dineen.
I'd echo that. I mean, I think there is a lot of hope. You know, I think that obviously there's a lot of work to be done, and there's a lot of new understanding, I think, each year in this immune sort of space and how it relates to cancer. What we showed in this presentation, though, is sort of a snapshot. You know, there's obviously many variations and different presentations. So what you can see here is, you know, there's all these avenues of research and also in the clinical space already for, say, peritoneal disease that goes to the liver or the lungs. Similarly, you know, we have parts of the team and the department, you know, that focus on the liver specifically, the lung specifically. So, you know, there's multiple modalities. They are usually a combination of, you know, the fundamental chemotherapies, radiation, and surgery, but there's certainly a lot to be learned. For instance, when you say what to look forward to, you know, we've seen remarkable responses in those subset of patients, those hereditary patients that harbor a mutation. That mutation is an indicator that immunotherapy will often be a highly effective agent for those patients with limited side effects. And so the question really becomes, how do we get the majority of patients to look to the body like it's one of those tumors that's missing that gene? How do you make a deficient tumor or a proficient tumor deficient so that we can monopolize on the successes of immunotherapy? And that's something that's actively being studied. And I think, you know, people are making headway there to learn more about these things.
Great.
Well, thank you all for all the insights. Thank you all for joining us tonight. We hope you found this webinar informative, and we certainly appreciate your continued support as we work together to revolutionize cancer care and provide the best outcomes possible for our loved ones. Thank you and have a good night.